However, today I also want to make the argument for dynamic assessment, especially for use in motor speech disorders in children, and especially in disambiguating those kids that have at least some component of childhood apraxia contributing to their speech sound disorder. So what is dynamic assessment? Well, it involves a process in which cueing is provided to facilitate performance. That helps us observe emerging skill, as well as often we can observe characteristics that we don't see in spontaneous production. It contrasts with static assessment, which is typical of most of the standardized tests we use, in which case those tests look at the child's well-established skills that are measured after a single response and with no cueing or assistance from the examiner. A dynamic motor speech exam offers some advantages, not only in differentiating motor speech impairment in children, but also allows us to see things we don't see in static assessment. For example, with dynamic assessment, we're encouraging the child to look at us, we're providing cues, which allows the child to attempt things that maybe they wouldn't attempt if they didn't have any support. And that's very helpful. For example, if I say a word and the child's attempting to imitate the movement gesture for that word, and I'm not providing any cueing, I just say, tell me, baby. The child is likely to do just what he typically might do, papa, perhaps. But if I'm saying, watch me, we're going to go, baby. Or I provide some tactile cues as support. I slow it down. Maybe even we do it simultaneously. That child might put forth more effort toward producing the accurate movement gesture. And certainly we might see behaviors such as groping that we wouldn't see if he just said it as if he was saying it spontaneously. Without that cueing, children sometimes don't provide that kind of effort or even attention. They've been here before. They've failed before. They don't want to do this again. At least in the tertiary center where I was, most of these kids have been in therapy, and they walk in the door and here I'm asking them to do something they've done many times before with failure after failure after failure. But with dynamic assessment, even with just a little support, I'm consistently surprised at the degree to which the kids will try harder to do things they've never done before. Now, in the case of evaluating children that we think might have some childhood apraxia, we have the opportunity to observe. Remember, we said assessment is just making observations about particular characteristics that we associate with one label or another, right? So in differentiating children that have maybe at least some component of childhood apraxia, a motor speech exam, especially a dynamic motor speech exam, allows us the opportunity to evaluate those characteristics that might be associated with that label, such as groping, such as inconsistency across trials as cueing occurs, such as segmentation of syllables, which may occur only when they're really trying to be more accurate with the segmental movement gesture. Or if they're trying to say an unfamiliar or a new to them word that's bisyllable or multisyllable. So dynamic assessment offers that little bit of support that helps the child feel confident enough to at least attempt imitation. And that's all you need, is to get them to make your observations as they attempt to imitate your very carefully selected stimuli on the motor speech exam. So, what is the rationale for a dynamic motor speech exam? Well, first, besides providing insight into the nature of the child's problem, the cueing used in dynamic assessment has the potential to facilitate judgments of severity and prognosis. I can't tell you how important that is. I once did a little survey for myself where people were always asking me, well, what kinds of questions do parents ask you? And I thought, well, I kind of know that, but I wonder what's real. So I just started jotting them down for quite some time, probably close to a year. And I just put them in categories. And when I have an audience, I always like to say, what do you think the most important one was? And people always say, when will my child talk? But it was actually more specific than that. The most important or frequent, the most frequent question asked was, will my child talk by kindergarten? Well, often we have to say, well, we don't know. But I never say that anymore because I usually do know. And I think, well, keep in mind, you have to practice a while before you feel confident about that. And that's just normal. That's in any profession. It's like pattern recognition. The more you see, the more confident you feel about that. But dynamic assessment can help you in that. If a child consistently needs a whole lot of cueing in order to make any improvement in the movement accuracy, or never produces it accurately in spite of all your cueing, it's logical to think of his problem as more severe. Certainly you know that at least the initial training is going to take longer. And the prognosis for rapid improvement is going to be more guarded. So by looking at how much cueing it takes and what type of cues it takes, you can make better decisions about severity and certainly have more realistic discussions with parents about prognosis. The other important thing about these judgments of severity is in a little bit we're going to be talking about the principles of motor learning. And I'm going to be telling you that a big part of making decisions about how to implement those principles depends on the severity of the praxis problem. So knowing or having a good sense of how severe this is going to help you implement these principles of motor learning with the greatest efficiency. For example, children with more severe praxis for speech usually need a much smaller stimulus set size, and we'll talk about why that is, and then it will gradually increase. We know that the more severe the child, maybe the more blocked practice we need at first, although we're going to move to more random practice as soon as we can. And we know that if the impairment in motor planning, processing, is more severe, we're going to provide very specific feedback early on, and then gradually decrease the specificity and the immediacy and the frequency with which we provide that feedback. So the way we implement these principles of motor learning depends on how severe the motor programming problem is. We also have a lot of help with treatment planning if we use dynamic assessment. The types of cueing that proved helpful in the assessment strategy, in the dynamic assessment, are identified, and therefore you can start implementing them right away in treatment. But also looking at the responses across utterances helps you with your initial stimulus selection. For example, you're going to identify specific vowels that are quite distorted across co-articulatory contexts and really choose those in different syllable shapes as your initial target. We'll be talking about how to do that a little bit in this talk, and we'll have a lot of practice with that in the more advanced on-site sessions that we'll be having. I think this idea of early stimulus selection has a lot of impact on how efficient and successful early therapy is. Now that is extremely important because you want to have the child trust you and trust this process, and you want the parent to trust you and trust this process. And rapid early improvement is a good way to help make that happen. So